Thank you all for coming to our third Thursday presentation sponsored by the Boothbay Region Health and Wellness Foundation. And we put on these monthly talks, and I'm glad to see some new faces and some faces who come to every talk. So thank you for being here tonight. Patty later on is going to introduce our speaker for the evening and the topic. But I just wanted to talk a little bit about the Wellness Foundation. We are a group of people who has a mission to, we're a nonprofit organization, and we have a mission to make the community healthier. And this is one of the ways that we're doing that by education. Next month, it takes place the third Thursday of every month. Next month is going to be May 15th. At 6:30 p.m. and that's going to be the Lincoln County Dental. They provide dental services to people there in Damariscotta, and they're also thinking about expanding to the Boothbay region, and so they want to talk a little bit about dental health, but mostly about what kind of needs the peninsula has in regards to dental health. So that'll be May. And in June, we'll be talking about a Boothbay Region Community Center and kind of another workshop where we'll be visioning what kind of health needs we have for the community and what kind of wellness needs we have for the community and what we want to see here in the region. So lots of good things coming up. And just as an addition to tonight's talk, in the spirit of ambulance and emergency care, we have some handouts from the Lincoln County Triad, and this is a group of first responders, and they put together these cards that go right on your refrigerator, and I'm sure Scott has seen them and used them, and they're handy for emergency responders to your home. They include your medical information, so if anybody needs one, the Triad provides these free, and we have them right up here. And they also provide a prescription card. It gives you 25% off of your medications, and it includes pet medications, so you can just take one. They just give these out to people. So very useful things, and I will turn it over to Patty, who is our president, to introduce our speaker.
Okay, so thank you guys for coming. We all know how important the Boothbay Region Ambulance Service is to us and to our health and wellness, and keeping us alive and keeping us healthy. And so Scott Lash, who's the operations manager, I keep calling him highfalutin things, and he keeps bringing me down to earth and saying, I manage the operations. Scott and Gail Evans, who is one of the members of the foundation, and for those of you who don't know Gail, she is a very high-powered strategic planner in healthcare with a specialty in population health, which means she knows how to crunch numbers about everybody's health outcomes and demographics and so on. So she and Scott invested a lot of time in putting together this report that's going to be the first part of our discussion today, which is the 2012 report. You may wonder, well, why are we talking about 2012? Because we're now in 2014. But the purpose of this is, we're calling it a baseline. And the reason is that all of us in the community, want to understand how was our emergency service before we lost our emergency department. So how long did it take the ambulance to get from here to there? What kinds of issues did people have that required them to go by ambulance to St. Andrews or to other hospitals? And so we basically wanted to know a lot about kind of the numbers and the time and the types of conditions people had. And then we want to keep doing it every year. So we're just beginning now to compile the numbers for 2013, and then we'll do it again for 2014. So we'll be able to see year after year after year, are we doing better or worse? Are more of us having more emergency issues, and are we dying sooner because we don't have a hospital with an emergency department at the base of the peninsula, or is this beefed up ambulance service actually able to meet our needs? So that's what we're trying to find out. And when Gail and Scott worked on this, again, the baseline telling us the numbers for 2012, she also put out a challenge to Lincoln County Health and met with Stacy Miller and Cindy Wade over there and said, okay, the ambulance piece, getting somebody from home to a hospital or emergency department, is only one piece. The second piece we need from you guys, the hospitals, from Lincoln Health and from Midcoast and so on, which will tell us, well, what happened? Did the patient survive? What were their outcomes? If they had a heart condition, where did they end up going? How did they get treated? And what were their outcomes? And the tricky part, as you can imagine, is gathering this information without violating any patient privacy. And so you have to do it by just looking at the numbers, not the actual, individuals or their social security numbers or their names or anything. And the numbers we're dealing with are so small because there's only about 500 or 600 kind of emergency cases each year on the peninsula, that we have to kind of wait till we have a whole pile of them, like at least a year's worth, in order to do that analysis and not be violating anybody's privacy. So that's why we're going to be doing it on an annual basis. And we're hoping that if we've had wonderful cooperation from Scott and his crew, and we're hoping that as we get more of that data, that will convince Lincoln County Health that they need to do the same thing for all of us and fill in the rest of the blanks. So that's part one of what we want to talk about. You all have this report to ingest and ask Scott questions about it, and he can also tell you kind of how it compares this year to next year. And then the new thing Scott's going to be talking about is our community paramedicine program. So hand it over to you.
Thank you all for coming tonight, and welcome to your ambulance station. Some of you are not sure if this is the first time you've been in the building or not.
What are all these body parts?
And whose are they?
They're learning tools.
After I finish and answer questions, it's all good. After I finish answering your questions, some of us here that are on duty can take you around the building and show you what's what, where's where, and sign you up and hand you a radio and EMT class application, and off you go. Thank you for coming. I appreciate you inviting me to present this to you. I have to give credit where credit is due. Gail did all the heavy lifting on this report. I just helped her fill in the blanks as best I could. So Gail did a lot of work on this. And as Patty said, a lot of this data is based on 2012. There's a couple reasons for that. First of all, that's the the last full year that we have of data that is going to help us compare apples to oranges. Last year we had the last quarter was a transition from one hospital system to the other, so it was hard to do a 9-month comparison as opposed to a full year. The other trick that we have is the software that's provided to us. It's a statewide software system. If we wanted to have our own, there's a few other different software vendors that we could use, but it's not provided free by the state. So it would be a pretty expensive proposition to go out on our own with a different type of software, which means that the vendor that we do use, it's a good software package, but it's really tricky to do any data mining that is consistent to what this community might need or what we're trying to compare with Lincoln Health. So it's hard to tease out some of those numbers, which is why some reports seem to contradict each other. Some numbers might have a few differences in them. For example, the total number of transports in one report might be off by 5 or 6 on another. It's statistical deviation, but it's still within the norm. So I think that's a little bit about the data. But basically what I can tell you is that the impact of the closure, as we've talked about a lot, has been prolonged patient contact time in the back of the ambulance, dealing with the same type of patients but for longer amounts of time. the number one, and it's not just unique to this community, but around the state, the number one reason that most folks go to the emergency room by ambulance is for injuries is falls. Cardiac, medical emergencies are a second reason why. And that's true for this community. And what we're seeing is by having to take care of these patients for a longer amount of time, it increases the amount of skill that we need for treatments, the equipment that we're using for a little bit, oxygen levels, which is an incidental variable cost. Drugs, instead of doing one round of drugs or getting to a hospital before we get into that, even in some of these acute cases, the first round of drug, having to do multiple doses before we get to miles. And that's not a bad thing. That doesn't mean that anybody is sicker when they arrive at Miles as opposed to when they did at St. Andrews. It just means that it increases what we have to do and how proficient we have to do at it. And that's a good thing. I mean, that just helps when we get on scene to have someone that's really ill that we know what to do immediately. So that kind of brings me to your question about what are all the bodies. We had a grant about 5 or 7 years ago, I think, that for an EMT class. And we had one simulation mannequin. And we had a family in the area that had a little bit of donation money left over from what they annually give to their different preferred outfits. And they had some money and asked, what could we do to help you out? And what we felt we were lacking was a simulation lab. So we bought a pediatric simulation mannequin, intubation heads, IV trainers, the newest standard that we have to have on the ambulances. Come on in. There's coffee in the back, help yourself. Urgent maintenance. Sorry. The latest standard that we have to have is all ambulances that are at an ALS level have to have an IV pump to give certain types of medications. And so we have all of our ambulances equipped with IV pumps, and we also, because of the grant, we're able to obtain a trainer pump from the station so that people can be so comfortable with it and do whatever, program it, deprogram it, mess it up and fix it, and we don't have to worry about impacting patient safety, and they can figure out exactly how to fix it, troubleshoot it, and we're good on a call. The other thing that we're doing is an AV, we're starting to see the wiring fragments of it, so we have ordered the pieces for teleconferencing. We've been hooked up with Londra Deneen, which has a connection with Mass General, so if we want to do any online trainings with them, we'll now have telecommunications to have a presence here in the building without having to travel down to Boston if it works out that way, or them having to come up here. It's kind of unique to have an ambulance of this size, to have one of these labs. This used to be a few months ago just our general meeting training room, and what we did here was our regular trainings that we had each month and used it for classes. But now we have this stuff out, ready to go, and it's awesome to see a shift. And I'm in the office doing paperwork and look over my shoulder, and there's intermediate EMTs showing some of the students that are in the class-based EMTs how they start IVs, so they're ready in their class, and people are just kind of messing around. Let's practice innovating, and so it just kind of enhances not only the camaraderie of the shift, but when you get on call, you're kind of practiced on that. So it's a good thing to have down here, and so it's a very, very generous and thoughtful grant. There are a few more pieces that we're working on to add to here, but that's basically about the station. So some specifics about the report. So I'll let you know. Some highlights. We are seeing about the same amount of emergency calls. There was a bubble October and November for emergency calls around the closure of the hospital. And then that dropped off to what we normally see despite what the hospital's status was. So we're kind of at par with what we were. January was a little bit of a slow month for us this year compared to the years before. That's not a bad thing. And I can't assign any value to that other than it was just a slow, general health season for everybody.
Maybe everybody went south.
Too much snow now.
I think everyone kind of camped in place. No one moved.
A lot of people got it.
Yeah, and a lot of people did. Yeah. As far as hospital transports, now, what the main impact is taking patients down to St. Andrews allowed us to do some creative resource planning. So if we had a hospital that was, for the most part, within 8 miles of wherever we were, give or take, obviously, if we got an Ocean Point, that's different. But for most of our call volume, we were within 8 miles of the hospital. So we had a real quick turnaround time, so that any multiple response situation, we could stagger calls and not impact patient care at all. We could have a call that would come in as we were rounding the corner to St. Andrews and transfer the patient over to the ED staff, saying, here's a quick report, we'll be right back, and we'll square up with you with the more detailed information. Go pick up the second call and come back. There's absolutely no impact, no difference in response time with patient care. Well, that's no longer the case now. Now we're up in Minnesota or even in Brunswick. So that drove us to recognize that the second out truck couldn't be either our own staff from the first recruit or a largely volunteer. When we talk about volunteers in EMS now, we're talking about people that are paid for a call, but the downtime or the time that they have to contribute to maintain their license, to maintain their skills, to maintain their involvement in the service is what's the volunteer part now. So it's if you picture your job that you work at and you go into the office and you work for a couple hours, get paid, that's great. But if you're, I don't know, if you work as a teacher and your prep time isn't paid, and if you have to go take a class to maintain your professional certification, that's not paid. So that's the volunteer part. And that's putting a huge stress on the system right now, statewide. It's not just us, it's around the state. Because they're recognizing that the patients that we see now need this high level of care. Before we could kind of get by and it was okay, and now seeing that we have a direct impact. The 12 lead EKGs that we do have to be done within 10 minutes of seeing the patient with chest pain. And that makes a huge difference downrange whether they're going to have a good outcome in the cath lab or not. So they're putting a lot more emphasis on pre-hospital medicine than ever before. So what that means is that what we're required to do to maintain our skills and licenses is huge now. And so it's driving this, what used to be a volunteer or a paid volunteer effort to be pretty much a professional occupation. And that's, again, not a bad thing. What has happened to this community is we have that paradigm shift pressure on top of a hospital closure pressure, on top of one of the worst economies that people have been through for a long time, so tax dollars are limited. So we have kind of the perfect storm for this community. So that's where, when people look at what our budget has done or what we're doing with our staffing models, it's not that we picked this time frame to just, this is it, this is our moment. It was all things kind of came together at the worst time. And we're handling it, and we're using this as a time for growth and a way to change how we do business. And that is a good thing. So 911, it's real important to still continue to call 911. We were not sure how it was going to play out, whether folks would use urgent care more, would that offset call volume loss by folks that used to drive to the ED because it was close at hand to now call 911 because they didn't feel safe and comfortable driving in the car? Or would they feel that there was a risk of calling the ambulance because of a lot of talk about people dying on the way to miles, so let's just go in the car and not wait for them? Or even maybe I'm not going to get the hospital that I choose, so I'm just going to say, to heck with it, and drive to Mid-Coast in my car and not deal with the ambulance. So we're not sure how this was going to play out. And we're still, call line-wise, about the same. I can tell you that Mid-Coast, anecdotally, without any particular numbers, have noticed an increase in their foot traffic, their walk-in traffic into the ED. I can't tell you how that compares to any increases at miles, I don't know. I just know that Midcoast has recognized that they've seen an increase in their walk-in traffic. About a third of our volume right now goes to Midcoast, which kind of drives the second crew, which I know is kind of an expensive budget item for us, but a third of our patient load for emergencies, we expect to go to Midcoast now. And to be able to provide that level of care, if a patient is stable, we have to make sure that town is covered. So that's why we have the second crew. Otherwise, we have to either stay in place and wait for another ambulance to come down, transport the patient to Midcoast, or leave town uncovered. So the next person that calls 911 doesn't enjoy the same benefit as the person who has a choice as to where they want to go. So again, it's really important. Yeah.
Make sure I understood that. So the
Yep.
second call, so let's say the first person said, they weren't critical and they could go
To
to
Midcoast.
Midcoast. Then the second call that comes in, do you have to take them to Miles?
No, we can still, depends, right, if we had Windjammer days and we had 30,000 people in the community and we'd already been to the hospital about 18 times that day and you can just kind of get the vibe that town's rocking, we might try to pull back and be a little conservative with that at that time. But in general, most cases, we're good to go. We can do what we need to do. Hopefully, the calls have come in that magical way that one crew is kind of turning around and we're headed back. It doesn't always work out that way, but we hopefully. So we try to give as much choice as possible, definitely. But there has to be, there's a discussion on scene with the patient and the family that, we want to honor your choice. But this is kind of where we're at. This is where we think you're at. We'll see what we can do for you and move forward from there. And for the most part, people are understandable. There certainly is still some animosity of what has happened, and people are resistant to going to Miles just because of what has happened, and you have to respect that. But there are times when that puts an additional strain on the system, and we have to kind of work around that some.
Have you found that they always have room for you
At Miles? So far, and this has been kind of a lull season, as far as patient overload, people in the hallways, that has not happened yet. Summer's coming, so we'll see how that goes. I do know that around the state, it's a problem, and you might have heard me talk publicly about this. I just kind of regurgitated the last news story about healthcare, that they merged they merged the Mayor Hospital system with Maine General and Augusta, and so they took the combined bed space and decided that even though those two hospitals were serving different communities, combined, those two hospitals didn't need that total bed space. So when they gave them their certificate of need, they cut the bed space. And then they found that as soon as they opened the brand new multi-million-dollar hospital, it's kind of like when the schools, I was on school board for a long time in Waldeboro, and they would open up these schools, and the state would say, no, this is what your student population is, and they put $12 million in a new school, and then they'd open it up and they'd have double-wide classrooms on the front lawn because the school was at what the capacity was 6 years before when they finally approved the bond.
Yeah.
So the same thing kind of happened to that hospital. So this whole healthcare, Affordable Health Care Act, what's going on in Maine with limited resources, with the community paramedicine that we're talking about, it's all kind of in turmoil. So that's just one more, in case we didn't have enough perfect storm, that's just added on to this. Specialty resources being shut down, moved around, pulled back so that one hospital is the leader in this and you don't have it at a small hospital. So those are all things that are happening to EMS. So we're left shuffling patients around. The last big change that I saw was around the AMI consent decree, when they had a lot of patients that had mental health needs were put back in the community, no problems there, but they didn't have the resources to handle that. So what would happen was, even now, when we do admissions to psych beds, it's usually after 11 o'clock. So that means you put an ambulance, a crew, a patient on the road at 1 o'clock in the morning, headed to wherever they can find a bed, which is sometimes Fort Kent, which is sometimes Mercy Westbrook, which is, and This is how that part of healthcare happened about 10, 15 years ago. And this is kind of the latest and greatest of just healthcare in general. We'll see how it shakes out. But more specific to Boothbay, definitely call 911. That is number one. Whatever time it takes us to get to a scene is more than made up by what treatments we can do en route. The big push now is cardiac arrest. The city of Portland has found that their survival rate has gone up by doing what we do now is a cardiac arrest in place. We don't do like the old days. We used to put them in the back of the ambulance and beat feet for the hospital and do what we could on the way. And they found, number one, the efficiency of CPR is bad. The pressure, the pump pressure of compressions without stopping or stopping as infrequently as possible has much more to do with survivability than some of the advanced interventions that we do. So we'll stay at the scene. And that means that if we have someone that doesn't survive their cardiac arrest event, it doesn't mean that we transport them anymore to try to get definitive care at the emergency department, because what we do on scene is exactly the same thing that the emergency department is going to do. So getting there actually decreases the chances of survival than if we just stayed and did what we needed to do, and the outcome is the outcome. And the city of Portland has found that. So that's another change for us, which means that puts a different burden on us, and it's a very, very small section of our call volume, but that opens up a whole new dilemma set for us. What do we do, and it's around the state too, what do we do with the patient after they haven't survived their event? Do we take them to the funeral home? What if we get to the hospital? And this is the actual protocol. If we're on the way to the hospital, the patient goes into cardiac arrest, we pull over and work the patient on the side of the road, because it's very inefficient bouncing down the road and taking these corners at high speeds to do anything that's effective. So we do it on the side of the road, in the ambulance, of course. But if they don't survive that event, now what?
Can you call it, or does it?
Yes, we can, yep.
You can.
Yep, it's in our protocol. There's certain parameters. After so many times, after so much we do. That doesn't mean that we don't have a collaborative effort with online medical control. We'll talk to the doctors and say, this is what we see, are you sure? You know, because you always want to give them that benefit of the doubt. But it is within our scope of practice now to call.
But you
Can't if it's forensic, I mean, if it's a...
That opens up a whole new, so
Yeah.
now we have a crew that's tied up, it's now an unattended death, so we're tied up on scene until law enforcement gets here.
Yeah.
So this is why when people look and say, well, why can't volunteer EMTs just come up? And I'm not saying that's everyday occurrence, I'm just saying that all these different
You've
pieces.
got to be ready for it, whether it's in the everyday.
Exactly. And it-
Especially in the summer when there's so much
Exactly, and it,
increased population.
right, and it changes how we used to do things. It can't be just, we commit a half an hour to a call anymore. This is a pretty major undertaking. So, we cover the 3 communities, obviously. We do provide mutual aid when we're called to Edgecombe if they need it. We do a lot of island work in the summertime population, and if we're available, the island of Montego doesn't have any ambulance service at all. They don't even have first responder services. And what they sometimes will do, their backup is lifeline, which means that if someone has a broken ankle, they've tied up a helicopter at $10,000 or $7,000, whatever the bill is, to go fly out there to pick up a broken ankle. And so what we do is if we have enough resources, and if we have, town seems to be very well covered, and we're having a day that appears like there's not a lot of volume, and we hear a call come in, we might offer, particularly if the planes are grounded because of fog, and we'll go out with the Coast Guard and help them out. Happens only a couple times a year, but it's another service that we can offer. It's something to look at. Certainly what the magic of making our budget smaller to a certain tipping point is to increase our volume so that our costs are spread, the fixed costs are spread around. And, you know, we always look for those opportunities. So, again, our time on scene, we try to limit our time on scene to 20 minutes unless we're in a cardiac arrest situation, or, for example, someone has a fractured hip. We have to spend a lot of time medicating them, depending on the circumstances, where they might have fallen in their home, to medicate them, to make them comfortable. to get them packaged up appropriately. But in general, a typical medical call, we try to limit our on-scene time to about 20 minutes and then get on the road. One of the things that we did implement with Lincoln Health was the telemedicine. We were the first ambulance in the state to have that. And one of the few around the country. I know that there are probably some pilots out there, but very few and far between. And that gave us a direct link to online medical control. We had, obviously, before radios and cellular telephones that we could check, but this gave a visual back and forth so they could see what we were doing or what we were talking about, interact with the patient if they needed to, and kind of see the flavor of what's going on with the patient so they could really get a good gauge when we're telling them. If you've ever played the telephone game, you tell them something and, it's legitimate, but something is lost in that translation and you can't lay eyes on someone. So this allows them to do that directly. We're also working on, with our defibrillators, we're able to transmit our 12 EKGs directly to them, and they can take that information because of the new data transmission methods. They can take that information and they can push it down to Maine Health, down to the cath lab, and the physician can bounce it down there now. And that's a piece that we're working on. We have the equipment to do it. We're waiting on some fundraising to do the modems, and then Miles has to do their end by implementing the software end. And then the cardiologist or even the emergency doc on his iPhone can be down in his room or her room and look at it and they'll see it. Right now what we're doing is we're reviewing what our interpretation is, which is within our scope of practice, but for them, again, to see it and see what we're talking and say, yikes, that looks like we need to get the cath lab warmed up. I'm going to send this down to Maine Health down in Portland, and Maine Med can take a look at this, and then the cath lab can get activated. So that's one of the projects that we're working on with them for this. We try to do most of our shifts, we have at least one, all of our shifts, we have at least one paramedic on. We try to backfill to have the backup paramedic, so that we can honor that commitment to take people to mid-coast if we need to. Again, it's hard to find paramedics and other trained personnel. There's a lot of pooling of resources right now, so the same paramedic staff or EMT staff will work for a bunch of different services. We're all in the same boat. A lot of us are not able to offer full health care, full benefits to full-time packages to keep costs down and to make our budgets as affordable as possible. So what do? You work a couple shifts for Boothbay, you work a couple shifts for CLC, you might work a couple shifts for Delta, and that's kind of how the system is put together right now around the state. It's not the best system, but it's the most affordable one we've got right now.
How many paramedics are there for the whole state of Maine?
Off the top, I just saw that recently. And I'd have to look it up. I think there are about 2,500 and maybe, I'm talking off the paper, so I think there's about 4,000 licensed personnel. I know that the only statistic that I almost passed out on is that there were 62 people with 30 years of EMS experience left in the state. 28 years or more. There were like 63 people
Do
left.
you have to have recertification?
Yep, every 3 years. And to do that, you have to have continuing at hours.
And that is at your own expense?
It depends. We try to offer as much as we can. We also send people once a year to the Samoset. They have a convention there. That's a lot of continuing ed hours. But for example, the paramedic license level, they just increased to 52 hours every 3 years. That's a lot of time.
Yes.
And that's where the volunteer comes in. We do pay some training time, and what we do is we give them like a $25 stipend every time they come. At Christmas time, at the end of the year, they get their 8 or 9 trainings, money, pay, and that's a little bit of a Christmas money for them. But it's not true payroll. It's not what it would be, what the investment is. If I need to go take an ACLS class, which is a day long for the recertification, or if it's a 2-day long for the full class, we're not paid for that. We did do 6 of our paramedics went to a critical care class, which is the same training that Lifeline has. And the only reason we were able, it was about a month long, and the only reason that we were able to pay is because we received a grant for the DeRay Taylor Foundation, and that covered the payroll. Otherwise, it would have been volunteer. So, again, that's the volunteer, paid volunteer. That's where the volunteer comes in for us. And that training is critical. It's critical for this community, it's critical for our license level, and it's how we maintain what we need to do. PHTLS, which is a pre-hospital trauma life support class, that's for all levels, and that's a couple days class. Again, that is worth continuing ed credits, but that's a 2-3 day commitment. So, yeah, our definitely continuing ed credits are getting higher and higher and higher.
So, Scott, when I was looking at the types of complaints,
Yep.
both the top 5 specific complaints and your primary impressions, I found myself wondering, so there are a lot of falls, there are a lot of other illness, injury,
Yep.
respiratory, et cetera. Can you give us a sense, without, again, violating any patient stuff, but are there clumps, are there, well, I also noticed in terms of the towns that, there's a lot of Boothbay Harbor, higher incidence of Boothbay Harbor patients to the population. I'm assuming that's because there's, housing areas there.
Right.
But, so the falls in particular, is this primarily older people falling?
Yes, I'm glad you asked that question, because this is one of the hard things about this software, or any software, and the data mining that has come out of this. As you look at this and you say, 17% of our call volume was falls, right? Do we have a bunch of people that live in our community that are clumsy, or that are just, to that age where they're living independently still and just fall all the time? And the real story in there is such a diverse answer. And what the real answer to this is, quite often, a lot of medical problems first present as a fall. Someone has a heart arrhythmia and they fall because they're just weak and they're trying to shuffle and they can't quite pick their foot up off the area rug, and boom, down they go. And we get there and it's a fall, which is how it's categorized, but their real underlying issue is that they have some sort of medical problem which has caused it. So that's why it looks bad. It looks like, clean up your living room, you're fine. But there's more to the story than that. That's a huge chunk of that statistic. But there's really stuff that's buried in there. To tease it out, it's impossible, because you have to look at secondary complaints and the software that we have, the categories we have to choose from are so vague in some cases that it's a real learning curve for the crew to really code this right. You think of medical billing coders and the classes that they take to get certified, and then you ask an EMT who, okay, now what are you going to code this as, guys? And, sometimes it's tough. And that shows up in these kinds of numbers. But,
So
most
just
communities.
anecdotally, if you just kind of, squint and say, okay, well, basically the patterns are X, we have these kinds of clumps of,
Yes.
we have drug people, we have,
Yes.
whatever. How would you characterize
We mostly have falls, injury, and then medical. Whether it's respiratory, whether it's cardiac, whether it's just general sick, medical, non-specific, flu-y, don't feel good type stuff that goes on. Those are the big things that we see. The high-risk trauma, it's there, but it's not a huge patient population that we have. We don't have a Route 1 corridor that we need to worry about. We don't have I-95 going through our community, so anything that we see trauma is someone falling out of a tree, off a ladder, down on boats, something like that. That's the trauma that we see. Now, that's not to say we don't have car accidents, but the trauma that we see is more of a occupational or home hazard type trauma. It's less to do with something else. So I would say yes, the falls. And then the falls lead into the big crisis now, is so many people are anticoagulated, they're on Coumadin or some other anticoagulation therapy, that a simple fall that we used to pick them up, you okay, fine, all right, call us back if you need us. That isn't the case anymore, because they could have a brain bleed, they could have some sort of other internal bleeding. So again, that turns into more of an assessment skill, more on scene, more interaction with the patient, and then ultimately more transports into the hospital.
What about drugs? Are we getting a lot of drug overdoses or drug-related stuff?
I
that you
haven't-
guys are seeing?
Not like we do in other communities. They are there. Some of it is probably the more, less scandalous drugs, alcohol, the general drugs. We're not seeing much of bath salts. We're not seeing much of the synthetic marijuana that's coming out. That we haven't seen a lot of that.
What about heroin? Have you?
Not a lot of that, not a lot of that. Most of it is possibly narcotic prescribed abuse. It's nothing that, it's the average run-of-the-mill, everyday overdose type stuff. It's not the things that you see on TV like bath salts that everyone's freaking out about.
That's good news.
Yeah, it is.
Yeah, that's good news, but I've heard that heroin was increased use, and I wondered about
Yep.
that.
Yep, other communities see that a lot more. Rockland, the area, saw a huge increase in bath salts. In fact, they drove the new protocol that we have for intervening with the bath salt patient. We've seen very few of that down there, very, very few. And even the ones that we have seen, it's kind of vague as to whether they really were on bath salts or not. So I can't say that we have anything that I would say, yes, it's here, we're doing it, we're seeing it all the time.
So when we had the ER, and maybe still with the urgent care, there's frequent flyers.
Mhm.
People who
Yep.
turn up over and over again
Yep.
because they've got an issue. Are you still seeing that?
Yep.
Are they needing
Yep.
ambulance service now to go
Yes.
further?
You always have a certain population of your patient that is just, their health conditions mean that they are frequently admitted and discharged from either the ED or the hospital, and that's not a difference that we see now. Maybe some of the walk-in, what could be walk-in nature that might have called us before, we're not seeing that as much, but we still have repeat patients that the medical condition just requires heavy use of either EMS or just medical resources in general, which kind of leads in a little bit to the community paramedicine, which is the pilot project that Lincoln Health has asked us to participate in. And I don't want to I know I don't want to talk this report, if we want to go back in a little bit, or as we're walking around, I can answer any questions, or any of the crew can. The community
I've got a question.
Yeah.
I noticed that the word ambulance is backwards on the front of
Yes.
all the ambulances. Why is that?
So the theory is if you don't hear the great big siren and the honking horn and see all the blinking lights, you might, in your rearview mirror, see the ambulance backwards, and that'll make you pull over, but, God forbid, all the lights and everything.
So it's still important for ambulances to get where they're going.
Yes, yeah.
Yeah. I got the impression from Dr. Foray last year that it didn't make any difference anymore. After all, we have these trained people in the ambulance, we've got an iPad on the wall, we've got these EMTs, et cetera. So it seems to me that you could save the money that was needed for the sirens and the lights.
That's right. I appreciate Dr. Flores' confidence in us and Lincoln Health's. I don't think that the crew that we have here is a great crew. They have a lot of experience. They have a big heart and a lot of caring for keeping the system going, but it comes at a cost. That resource comes at a cost. And the cost isn't done lightly, it isn't done with the.
It's also to be noted that that cost does not appear in the budget of Maine Health, or Lincoln County Health, or Lincoln, whatever it is.
Yeah, I would say not. And just because of some safe harbor regulations that involve Medicare, we, on the advice of legal counsel, backed away from any negotiations with Lincoln Health about any sort of subsidy. And they provided us with the iPads for the communications, but we were the test site, and they were expanding that to other services, so that made it okay. We do use their central supply to purchase at their rates some medical equipment, the consumables. There are some specialty things that we have to use that they don't provide, that we have to order from the catalog. But there are some resources that they do provide us, but it's common to all ambulances, so that way we can avoid any safe harbor violations. But as far as the subsidy stuff, I'll let you speak on that. I'm going to take the advice of our attorney and say, don't say a word, Scott. So, yes.
Throughout all this, and I read it through very well, and very well prepared document. There's one simple term in there,
Yeah.
which gets to the crux of the whole problem. And it's allowable cost.
Yeah,
That's what you get paid for.
that's correct.
Who is the magic allower on high that decides? Seriously, because,
Yeah.
well, I'll give you an example. If my oil burner stops in the middle of the night, I'll call the oil burner company. They send a guy out, and it's $58 for his run and whatever parts and so on, plus hourly.
Right.
Yet you are much more highly skilled. You have lives in your hands rather than plumbing. I mean, metal plumbing as opposed to human plumbing.
Right.
Yet, you have a domineering force on top of you that doesn't pay your money. Now with life flight, they're $10,000 and $12,000. Who pays the $10,000 and $12,000?
They are capitated just like we are.
Yeah.
And our payer mix is 75% Medicare. We have about 15% private insurance like Anthem and Aetna and Cigna, those types. And then the rest are made up with main care, and the final balance is self-pay. So 75% of our revenue stream outside of town subsidy comes from Medicare. Medicare sets, they used to do it 5 years ago, they did it what was called the prevailing rate. And there was a sliding scale.
I mean, they use these
I know these fancy terms.
These terms of our prevailing rate and allowable rate, and so, it's money that you don't get.
Right.
And you people train, it's difficult to recruit EMT candidates because they have to pay their own tuition, they have to.
Right.
Yet, and again, we go back to nothing against plumbers. Oil burner technicians are important when it's 3 degrees. But they get paid.
Right.
Well, what happened to Medicare, and why is this? Medicare has been a failure for half a century since it went in, and nobody seems to worry about
Worry
that.
about it. What's been even worse for us is main care, the Medicaid.
Well, that's, yeah.
And those reimbursement rates are still stuck in 79.80. I mean, we're reimbursed $90 for a base rate and $2 for 100 mile.
But you're reduced to having to go to the towns as a mendicant practically,
Right.
and ask for, well, public assistance.
Yep.
And that's,
And what they did to us.
it's demeaning to you.
Oh, it is, and what they did to us last month is they wanted to renew some legislation, and the fee schedule, which used to be prevailing rate, so all the ambulances in a certain section of the state, they kind of averaged the cost and determined with some, they call it the Goldsmith modifier, and they kind of figured out some things and said, well, your ambulance trip may be billed at $10 a mile, but it's kind of worth for everybody $7.50.
Yeah?
And so what they did was they scrapped that system and just set a national fee schedule with a little bit of an increase for areas depending on what they felt was the resources of the community. If you're in a rural state, you might have less volume, so you might need a little more reimbursement. Or if you're a large city with a higher expense, you might need a little more reimbursement. And they also did what was called a super rural, and they phased this in over a couple of years. So mile 1 through 17 was at 1.5 times the base rate of mileage, and mile 18 through 50 was at 1.25, and then above that was an even higher reimbursement. And what they did was they phased that out until the last 50 miles and above, which pretty much for us is just a trip to Maine Met. And a couple, I think 3 weeks ago, they had to renew the legislation, and they held up the fee schedule. And what that meant was for 2 weeks, at least this area, meaning this area of Medicare, which is Maine, New Hampshire, Vermont, and some other states now, they couldn't pay out Medicare until they cleared up this computerization and programming issue. So there were no Medicare payments that came out for 3 weeks. So when you talk about revenue stream, and this is the slow season, so that summer bubble that we usually experience, if this had happened in September, we'd be fine because we still have stuff coming in. So that's why, the last month or two, we've been looking at a revenue stream. It's kind of like, not only is call volume low, but on top of it, they're withholding payments, so it's kind of dipped down. And so now out come the subsidy requests to finish up and then to bring us back up. So they play little tricks like that. So it is tough.
So are they going to reimburse you?
Yeah, it catches up. We're starting to see the payments arrive today, but for 3 weeks, you're kind of wake up, where's the money, what's going on? And if you have a snag, like, the billing company has to do this just right, and they have to have all the signatures, all the medical necessity, all the forms, and all that. So if there's the least snag, then it has to go back, we have to get that all squared away. On top of it, they withhold the Medicare money until, so it just slows down the system. It's bogged down not just with us, but everywhere.
That's one thing, but you still wind up $300,000 to $400,000 short at the
gosh,
end of
yes.
the year.
Oh, God.
Because
Yeah,
Medicare
yeah,
says, this is the way it works
Right.
because
And
we've sat in our office here
That's
and
right.
figured it out.
and on top of that capitated rate, they only pay 80% of it.
Well, I understand that.
And so the 20% copay, and for those folks that every dollar that comes out of their Social Security is important, they may not elect to have Medicare B. And Medicare B is what covers the ambulance. So they'll just say, I'd rather have that couple $100 a month coming to me so that I don't have to have that come out of my check. And they say, forget it, I don't need B. Well, B covers the ambulance, physicians and lab. I mean, B covers your ambulance. So if they don't elect B, they're gonna get this $800, $700, $600, depending on what we're doing, bill, and it's out of pocket. And
But when you look at the 80/20, it
$5.
looks good, but it's 80% of allowable costs.
that's right.
Which means it's 80% of whatever Washington wants to give you at a given time.
That's right.
And I don't think that the general public, not of this peninsula, but of the entire country realizes
That's right.
that they are just playing with the money
Right.
down there.
It'd be like going into shopping center and saying, I like that steak, it's a $10 steak, I'm gonna give you $7.50 for it.
Right.
We're gonna give you medical care
Right.
like you've never seen before, yeah, right? And it is. No, you probably think of me as an antagonist over the
No,
years.
I totally
I've
get
studied
it.
this.
I told you, because I can't look at our vendor and say, thank you for the gauze, guess what? We're only gonna pay you 2/3 of what it's worth. I mean, we can't do that, so it's
I
kind
mean,
of.
I pay for my Part B and I pay for the 20% another way.
Yeah.
But all of my care is through the Veterans Health Administration, and you know what they get out of the 80%? Zip up.
Zip out.
They get the 20%.
And if you're for your, anyone that has a VA benefit, then you have the travel benefit, which means that you have to be in certain circumstances for an ambulance that's not one of the contracted ones from VA to cover it. So, for example, if you needed to go to the local ED, they, after a long time, will cover that. But if you needed to go to another facility, you have to wait for one of the contract ambulances to come down. You can't have the local that'll come and take you and pick you up and bring you. So you might wait a while.
Yeah.
So it all depends. It's a weird system.
No, it's just I wanted to emphasize to people, and everybody I talk to, I try to tell them that Medicare has been broken for decades,
It doesn't,
and nobody goes after it.
it doesn't pay what,
No.
no, it does not, I mean, it's there and it pays, but it doesn't pay what we bill.
It's a trust me system, like the used car, that trust me, to add an engine.
Yep.
So are you saying if, let's say I have to take the captain to Togus, I can't use you to get him there?
Right, if you're gonna go to Jamaica Plain, you're gonna have to have one of the contract ambulances do it. And they have a specific contract with a few ambulance providers in the state that does all the VA patients.
Well, he doesn't say Jamaica Plain, he's talking about Togus. and
Togus, if you want to go direct, they don't have an ED per se, they have their clinic.
Yes, no, that's not true.
Well, but not,
They have an emergency department.
right, but not one that receives
Yes.
ambulances like that, no.
No, I know, they tell you to call
They-
911.
Right, they did away, God, I don't want to hate myself, but way back in the early days of my career.
It's okay.
Okay.
We're all there.
Speak for yourself.
We know you're only 21.
I'm glad that I started when I was 15, so thank you. Otherwise, I look back, I would just go, oh my. Anyway, we used to take patients to Togus VA, and it was a rare occasion, but I was in Waldeboro, so it wasn't that much of a stretch to go to VA in Augusta as opposed to going to Penn Bay, another 10 miles, especially if we were in Washington or Jefferson. But they just don't like that anymore. And they want you to go to local, and then they kind of balk as to whether they're going to pay it or not, because it falls under their travel benefit. So,
You know, as far as I'm concerned, if your ambulance, and I've been cared for by it, and I've watched it in other places, it is basically a four-wheeled emergency move.
we try, yeah, it's becoming more
It
and
is.
more. And the next part of what's coming at us, thank you. The next part that's coming at us is the community paramedicine part. And that is not only mobile emergency room, but that's mobile health care in general, a broader spectrum. And where that's going is, in some regards, we're doing some of the things that the district nurse here does. It's a unique community that it has that resource. There are other communities in the pilot, and we're one of 12 in the state that were awarded the pilot. We were the only one in our pilot program that was awarded a grant. The Ray Taylor Foundation stepped up again and provided us, a couple of weeks ago, they notified us that they are going to give us $60,000 to implement this in the community. So it's a resource that we don't want to take away anything from the district nurse, but we do want to offer this and make use of that, make use of this resource. So what we're doing is we're identifying patients that are at high risk of readmission, at high risk of having declining health, that don't have resources like a district nurse, like home health, like being able to have family members take them to their family doctor or whomever to take care of them, and being able to put the ambulance in a non-emergency setting in their house to assess them. So a good example of that would be, let's say someone has a pretty substantial history of heart failure, and they are unable to monitor themselves and end up frequently in the ED with congestive heart failure, and they're having difficulty breathing. So the treatment plan might be some diuretics like Lasix, and coming back, regulating their diet, making sure they're not eating high salt foods, and getting checked regularly. Now, for you and I sitting here today, that sounds pretty easy. You go to your doctor every couple of weeks and make sure that everything's okay. But for other people, that's a hardship. Just getting to family care is a hardship. So what are we going to do? What are we going to do with these patients? In the past, it was they get worse and they get worse and they get worse, and they go home and they eat their regular diet because that's all they can afford. They maybe are compliant with their diuretic, maybe they are, but even still, their disease process is getting worse and worse and worse. And before you know it, now they're calling 911 when they're full edema, they're full up to their lungs, and now they're really sick, and now they have to go to the hospital. We have to put them on CPAP, and they're in ICU for a week, and possibly on a vent, and then they're discharged, and then we repeat the process over and over again. One of the things that's happening is the Affordable Health Care Act is reimbursing hospitals based on how many times you get readmitted. And so if you have a really sick patient that might be one of those ones that need to get revisited frequently, it cuts down how much the reimbursement is. That's one piece of the puzzle. The second piece of the puzzle is that there are communities with less volume than us that are we're trying to figure out, what do we do? We're going to have to pay paramedics or some sort of licensed personnel to be on station because we can't be as volunteer anymore. So how are we going to pay for this? So we pay for it out of tax dollars because there's only so many calls to bill and get reimbursed. And so what are we going to do with that time? That seems like a real expensive capacity, like St. George has done this. 300 calls a year. So what are we going to do with a full-time paramedic for 300 calls a year? We have to have it because we don't have the volunteers, but what are we going to do with that in-between time? So this is where community paramedicine comes into place, where they say, we have this resource. What are we going to do with it? I know we'll have someone that has been discharged, and part of the treatment plan is you're in heart failure frequently. So what we're going to do is we're going to have the EMTs or paramedic come by your house once a week, maybe weigh you to see if you're starting to retain fluid, count your pills to make sure you're taking Lasix, listen to your lung sounds, see if some of the medications that you're taking are compliant or not. And then before they get to the point where they need to call 911, have a conversation with their doctor and say, you know, Mrs. Jones is starting to sound like she's filling up a little bit. Okay, well, why don't you tell her to take this much Lasix instead of what she was taking before? Well, let's see how it is for the day or two. And then we come back, and it's either intervened in the situation or it hasn't. And that prevents them from coming in and being in a worse condition. Some of the other services that we can offer is vaccinations for patients that can't get to a flu clinic or a pneumonia clinic. Blood draws for people who can't make it to lab to check their INRs to see what their coagulation therapy is like. Listen to lung sounds, check wounds to make sure that they're healing. We have a wound clinic that's coming to the area. Just be more involved in the everyday healthcare aspect, which helps us. It keeps us familiar with our patients. It gives patient care time so that skills are retained, and it uses our in-between time for something other than just waiting for the next big call to come in.
Doesn't the district nurse do a lot of that?
She does. Her load is about 50 patients right now. And again,
That's what I'm wondering, if you could collaborate.
we are, yeah, we're meeting with her and
Yeah.
collaborating. This community specifically in this,
That's what I just,
yeah, in this community, this is really unique to have that resource.
exactly.
In the other grant, we're one of 3 services. CLC participates, Waldeboro participates, and we participate in this one license pool. And we're the only service that has a district nurse resource. So there are some things that we compete with, there are other things that we don't. So we're going to, it just started a month ago, so we're kind of weaving in to see where our role is, where we can meet with her, where she might be overburdened, or where she's not meeting needs, or where we can back off and focus on other
Do
things.
you do any teaching, like, to people like diabetics who need to know and don't about the diet and, you know, what they need to do to make themselves stable?
Right now, our scope of the pilot is specifically on treatment and intervention and just recognizing healthy situations. For example, it's not a home safety check, but to eliminate some of those false statistics that we were talking about earlier, to go in a home and see, to not do the occupational stuff. Like go in and say, okay, you need to have a chair rail here and make sure that your commode is up this high and there's a rail here in the shower. But at least to do a general overview and say, you know, geez, you know, your area rug is kind of curled up here. Let's get some tape down so that you're not tripping over it. But the diabetic treatment, it's not that we can't do it, it's not in the scope of this initial round of the pilot. We can expand it from here. This is where we kind of plunked down the flag and the map and said, this is where we're going to start, and where it goes from here, we'll find out after. It's a 3-year project.
Because I used to see patients, and I would go and negotiate with Boothbay, so they would get fresh fruit and stuff.
Yeah.
Because some people just don't know about it.
That's right. And the reason why we did it the way we did is because we wanted to make sure that the staff that we had and it's not just our staff, but it's the staff of the whole system, to make sure the staff that we had the training necessary to do that. And that's why we kind of steered away from some of the home safety stuff, because we're not code enforcement officers, we're not trained in heights of things. And to take the skill set that we have now, so that it wasn't putting an additional burden on the crew and say, okay, let's take our training that we know now, how can we apply it, and then later on, we can get into, expand it to things like that.
Well, what's the liability, Scott, if you make a call with congestive heart failure and that person, it develops a little quicker? Who does that fall back on? Is that falling back on Lincoln County Health? Does it fall back on the ambulance service? What about liabilities with this?
It's underneath our entire EMS Act of Maine. So the liability is no different than if it was an ambulance call and it was a sign-off. And it's a collaborative effort with medical control, which may be the online medical control in a 911 setting is the doctor in the emergency room. This is the primary care physician. It's patients that are, it's not uncommon that we could find someone that is that kind of precarious in their health care, then the decision would be to transport them. But if you get into that situation, there's a decision tree to say, okay, you actually need transport, we're recommending that you go to the ED to get taken care of, and it gets immediately filtered back to their primary care if it's not transported. So if we have, it's more of a live discussion, it's not so much go there, take a look at them, fill out a report, fax it back 3 days later, and meanwhile they're getting worse and worse and worse. If we have someone that's that dicey, it's more of a live, online, this is what I see, what do you think? And then our liability is no different than it would be if we had a patient that might have fallen, feels fine, isn't on clean and they decide to stay home, they sign off, they release us from transport, and then maybe get worse later on, something that was unseen at the time. Maybe they didn't have a hip injury that was prominent then, and a few days later, it's like, oh, well, that's right, they actually might have had a hairline fracture. It just took a few days to kind of stress and work itself to the point where it was obvious. So, no difference in liability. It's certainly a consideration that we have, but we try to work really closely with our medical direction to make sure that we have that taken care of.
Well, we have a situation in St. Andrews Village where somebody who was employed there was taking things from rooms, and what if something's missing from somebody's home? That's really kind of, have you considered that?
We have.
Not that that would happen.
No, I understand, yeah.
It's an interesting dynamic that goes
It is.
with this.
It's, I guess the situation could happen, no different than an emergency call, but we see this probably is happening in the pen. We're going to get some experience with this and see where it goes, but most likely it will be a two-person crew that goes out, and more of a duty crew that heads out.
Oh, that's good.
If it's a real busy day and resources are tight, possibly it's just going to be one person, but we're going to have to definitely check into all aspects of it and make sure that we're doing this right, make sure that our experiences are that the patient is feeling safe with the encounter, and that the crew isn't at risk for, even if it's false reporting, even if they say, geez, they could be a seeker and say, oh, I had a bottle of oxycodone and the EMT came to my house and it's gone. I want a refill when I took them all. So usually it's probably going to be a crew or two that goes. It's not to say it's going to be every single time, but most likely it will be. Yeah.
Scott, we're having, at least at Bay Landing, I don't know about the other places, excuse me, we have people over there that just don't understand why you're sitting out front. The patient is in the rig.
Yeah.
And I have one lady in mind, I won't mention names, but she really came at me, and I tried to explain to her, is there any way that you could have a program and come back over to Bay Landing?
Sure.
And, excuse me, and advise them of what is going on.
Sure.
They just get sort of concerned
Yeah,
things.
yeah.
And what's taking so long, and this particular person happened to be a patient in the rig,
Yeah.
did not understand,
Yeah, yeah.
and, you know, they
There's a
just-
lot of things to that puzzle. Certainly, I would go down to Bay Landing and talk to them, and I will happily go down as many times as necessary, and a few more on top of
Yeah.
that. It's all situational. There are some patients that might be, for one reason or another, a hard IV start.
Yeah.
We don't generally delay transport for things like that. Well, let's say someone is dehydrated, and I'm
Yeah.
not saying that's the case in this one, but the patient may be dehydrated, which automatically, you're
Right.
starting off with a hard IV start, and
I
bouncing
have
down
an
the
idea,
road
but they
is-
don't. and
Exactly,
they're
it's all
really-
education, it's all
Yeah.
still the mentality of
Mhm.
get in the back of the ambulance, turn the lights on, and work them to the hospital.
The
And
old
that's-
bag and drag.
That
as they
is,
used to
and that's
say.
not where, that's not
Arthur knows
where,
that. Arthur and I know that. Yeah.
and
When
that's
they're in
not,
the bag, it's too late.
Oh, that was Sonny's job.
that's right, and that's not where medicine is headed anymore. They want us before we go to get that, I mean, there is protocol now that we
Right.
have to, and we're held to that standard, 10 minutes to do a 12 lead EKG, within 12 minutes of arriving on chest pain. So to start, I mean, takes a couple minutes, you can do it
Yes.
quickly, but it's not, to do a clean one, to make sure you're getting the right type of tracing, you have to do it right. And so there's, when you're sitting outside wondering what the ambulance is doing, that's what we're doing.
Especially if it's a loved one in the rig.
Exactly, and what they don't understand, which the message is that 10 minutes extra treatment on scene, in large case, now this doesn't mean that we like to hang out forever,
Yeah.
but in those brief 10 minutes on scene might make a huge outcome later on down the emergency room, so that their stay there is briefer, or that their disease process is stopped to the point where their outcome is going to be better. Now, that's not to say we're going to sit on scene for an hour like they did Princess Diana in France and work on her for 2 hours, when she should have been in trauma surgery.
Yeah.
But there's a time and a place for us to be on scene, to do the brief things, the 10, 15-minute things, that make a huge difference down the road.
Right.
And
I think that's
what-
where they're not, people are not catching that.
That's right.
And that should be
Right.
out more public, awareness.
Yeah, she did. SOMA, the French system, the trauma services.
I don't want to know that, I love that.
Their trauma services, she had a pulmonary artery rupture, and her trauma services for France, the SOMA system, their system is based on the physicians in the ambulance. They come to the scene and they treat them there. Now, what her outcome would have been, I don't know. I mean, I'm not a Princess Diana follower, but just using her as a popular example of how that works, is that their system is, they stay on the scene and treat her. Now, there's nothing you're going to do with a pulmonary artery tear in the back of an ambulance, no matter how good the crew is. She needs to be in surgery. That's her best chance. So that's the reference on that is, they were 3 miles from the hospital, sitting on scene for 2 hours. Well, they could have been, so using that as an extreme to demonstrate your point, is that there's a time and a place. That wasn't the time or place, but maybe starting an IV, maybe doing that 12-lead EKG, maybe drawing up that drug for 5 minutes is the time and place, because that's going to affect their outcome later on.
Thank you.
I just want to come back to the community paramedicine. I think somebody asked the question about the district nurse, et cetera, and I spent some time today talking to the district nurse and the home health nurse and so on, and kind of sorting out how this is all going to work. And it's actually pretty cool that we have one coordination, and basically your doctor still needs to refer either the district nurse or home health or the community paramedicine. But they've got it really well kind of orchestrated. So if you need skilled nursing, then home health will kick in. If you need less than skilled nursing, then, and it's like you need to get there pretty quickly, and, go check on, the doctor's worried about you, whatever, he doesn't want you to have to come into the office, then they're gonna call you guys. If you need kind of ongoing, every, twice a week, we need to go check blood pressure or whatever, that's probably gonna be Callie, the district nurse. And so it's, and it may change based on the patient and the doctor and what people want, but it seems like that's gonna be a really nice safety net for us, because, as you said, Callie's already got about 50 patients, and when I talked to her, she said, well, right now my load isn't overwhelming, but there are a lot of people who don't even know I exist. And if everybody who actually needed the service took advantage of it, she would be completely swamped.
That's right.
So now we've got, we can publicize this as another thing, and as long as the doctors know about it and they are referring. And then the other thing is, if you don't have a primary care doctor, you can still get into the system by calling Callie directly. And she will actually come to your home, do a quick assessment, and then you'll be in that home health system. You'll have to still be referred to a doctor along the way, but you can get her to just come and do one assessment and then connect you to the right resources.
Scott, did you say she has 50 patients, or she has a limit of 50 patients?
No,
No,
she
she has.
has
Has
a
a
caseload
caseload.
of about
Yeah, her
50
caseload
patients.
is-
But that's not her limit, right?
No,
No, I don't know what her limits are, but she has a caseload of 50 from what she told us the other day.
Yeah.
I suspect, depending on how the Affordable Care Act finally shakes out, I suspect that this, I don't want to use the word pressure, but this expectation of community-based medicine, the old-fashioned home doctor visit type stuff, is really going to be a pressure on the system. And the more and more that experience proves that it's effective, the more it's going to be pushed on to do and encouraged. So I suspect that it may not be this year or next year, but down the road, I don't think she's going to have just 50 patients. I think this is going to be something that is, for the most part, here to stay unless the paramedicine pilot fails, system-wide, but it's new to me. But once it fails, I think it's going to be more and more expected to do. They did it in Minnesota, and again, these are numbers off the top of my head. I think they saved $16 million, was what they found with patient numbers by having home visits from, and when I say paramedicine, I don't mean necessarily paramedic, but some sort of EMS encounter in a non-emergency setting, whether it's an EMT, depends on what the scope is of the program. Our scope is written for any license level, and then in that scope, if there's a specific treatment like a vaccination, that would be a paramedic or an advanced EMT. If it's just a blood pressure or medication reconciliation, they call it, when they check to make sure the meds are all, that would be any level, it could be an EMT. So it has proven already that it saves money in the long run. Now, again, getting back to Palmer's point, that money doesn't come back to the community because it's not a reimbursed service yet. But system-wide, when you start to pile up all this healthcare dollar, that comes back to either Medicare or Maincare or whatever the system that's funding it is, it does save money in the long run. Now, it just doesn't directly come to our pocket. It's not like we can go, charge for that, and then we get it in our operating fund. It doesn't work that way, but in general, for right now, it saves the whole system money.
I want to ask you a question about the budget. You say that insurance paid 80% of your annual costs. What insurance is that? Is that Medicare and Maincare, or is it
I can,
private insurance or what?
no, I can tell you exactly. Like I said, 75% of our payer mix is Medicare. Now, they set what they say is their fee structure. And so let's say, let me do this on even number, so I can.
Well, what's the other 25?
I'll give you exactly. 6% is Maincare, 13% is private insurance, and by private, I'm talking about Anthem, Aetna, Cigna, and then, what's that, 6% is self-pay. So depending on what kind of insurance you have, if you have an HMO plan, their reimbursement rate is sometimes on par with what main care is, and main care's reimbursement is awful. They haven't had an increase for years, decades. So with the prevailing schedule gone, the fee schedule is, if this call is $500, Medicare says, nope, it's not a $500 call.
And I
It's a
was curious
$400
to know what
call.
the breakdown was between the private insurance and
That's our payer mix on average. Now, next year it might be 78% that's Medicare, but in general, that's what our payer mix is.
Is that big screen behind you, is that what you were talking about? You see the doctor in that thing and he sees
No, I
you?
will show you, I'll take you on the analysis.
What's that?
This is
TV
our,
set.
Training.
this is our regular TV that we use.
That's a TV?
Yeah, well,
Don't tell him that, he'll want one at home.
Scott, my TV, it's not connected to the world, but my TV set is about this
Exactly.
big. I thought that was the screen you talked to the doctor.
no. We were, a couple of years ago, we did an EMT class here, and we kind of, do we get a LCD projector for training, or do we get a TV? And we weren't sure which way to go, and it seemed like the easiest, like we just had the experience, like trying to find the right connection, so we just said, let's go with that and a DVD and a VCR and hook it up that way, as opposed to a projector.
So you can use that as a teaching tool.
That's right. This is what's hooked up. We have, our DVD player is hooked up to the internet. So we do, for example, we had thermal angel warmers, which are inline IV warmers. We were able to put the YouTube clip on here on how to train, so the crew could come in here
Great.
during their shift, in service on how to use the equipment. It will have, we've ordered today the rest of the parts. We have a conference phone so we can talk with any of the training sites that we need to, and then we have a webcam we've ordered that's coming, so that will be broadcast through this system. So if we have any opportunities to do remote, so that we don't have to put people on the road, going to conferences, we can now take advantage of that. So that's what's great.
Is that set up so you can see the person?
It will, yeah.
You can see the person you're
That's-
talking to?
We ordered the parts today. This grant that came in,
Wow.
we've been working on it for the last couple of months. Our first focus was to get the SimLab stuff together, and now we have a little bit of money left over from that, so now we're working on the telecommunications so that we can be able to, if we have the opportunity. It was, not a lot of money, so we were able to do it and say, great, let's hook up, and maybe there's going to be a training site or a physician that could Skype with us for an hour during training and not have to come down here from Bangor. We did have, last month, we had some of the local physicians do a training for us, so that's easy. But if we have a specialist that, might not, my dad is a teacher for SAD 40, and he does an heirloom seed project, and he Skyped with Australia and did classroom time for a couple hours. And so that would be kind of a setting. They get a unique training experience, and we can Skype and not have to worry about the expense, or maybe only 2 people can go, or we can get that online. So we're definitely moving in that direction as fast as we can.
Telemedicine in the ambulance, is this on iPads?
Yep, it is. It's on.
Is this using the regular FaceTime
It's-
program, or is
yep.
it specialized?
We tried ClearSea, which is a specialized medical program, and it didn't have a good connection because of the 4G network. It's a secure array, so it's HIPAA compliant,
Yeah.
and it's a stable system. So we just use the general FaceTime,
FaceTime? Yeah.
which is great for me as the manager, because I have an iPhone, and there are times
Yeah.
when I can say to the crew, call me, I want to talk, and we can all have a better communication experience
That's
that
what I
way.
was thinking, there's probably no need of specialized, it gives you all you need.
Everything you need. If you have an iPhone, there have been times when I've been on scene and I've used my iPhone to talk to the doc that way. It's just a great resource.
Yeah.
Yeah.
Oh, cool.
Scott, this has been really good. You promised a tour.
Absolutely.
We've got about 5 minutes
Kept you
left.
forever, I'm sorry.
No, it's okay, it's good. I just want to remind people, if you don't have one of these on your fridge, it may save your life. Please grab one and fill it in and put it on.
Another
Is
thing
that-
is,
Isn't it
it's
when you
like,
put it in
I
front door?
graduated 57 years ago in nursing, and we had public health nursing then,
Yeah.
which they did away with.
Yeah.
And it seems like it's
Coming
just coming
Coming
back.
back.
Yeah, right.
Okay.
Scott,
Exactly.
Do you look for those things on refrigerators?
Yeah, we try to very much. I mean,
And so if you have special peculiarities, like I have to have a pediatric intubation kit used on me, which I didn't know until I got in trouble.
that would be good to know.
That would be something I would put in there.
Yep,
And do you have both in the ambulance?
Allergies.
yes,
Okay.
yes.
That, I feel much
Well,
more.
we have, what, our intubation equipment is from neonates, preemies, all the way up to adults. So, I mean, as far as specialized, we have all the sizes that we need. If there's like something really, really particular to you specific, maybe not, but we have all, I mean, size, I mean, we
Well,
have
it's better if you know that before you start.
Right, 2.0 all the way up to 9. But that, two things about that. Number one is if we're in that kind of a crisis, we might not, if we're in that situation where we're
Right.
doing airway management, we might not think to look at
I've
that.
been thinking about getting a tattoo.
I know there's a lot of people now that have DNR tattoos.
Oh, I know that.
You'd be surprised how many we run into now. It's not recognized.
It doesn't take the place of the papers.
It doesn't, but I would definitely recommend getting a medical alert bracelet or
That's a
necklace.
good idea.
Yeah, I definitely
I'll do
would.
that.
And I just saw this box of expired medications, and I am reminded that I was supposed to tell you that there's a medication take-back day on next Saturday.
April 26th.
April 26th, and
During-
it's at 10,
Windjammer?
it's 10 a.m. to 2 p.m. Yeah,
I'm doing 5 sites.
It's,
And Boothbay Harbor Town Hall, Miles Hospital, Wiscasset 911 Comm Center, Chipskip Valley Health Center, and the Sproul Block up in Marlboro. Those will be the 5 sites, and it's from 10 to 2. And the last April, we collected in Lincoln County 22,000 pounds of medications.
Wow.
We are, the state of Maine is number 1
Johns, isn't that wonderful?
This
in the
settlement
country
is done.
per capita.
That's right. Those are those are pretty. There's the water stuff. There's nothing that's scary.
How does the DNR affect the ambulance crew en route with the physician at the hospital that you're speaking with?
Less so than it used to. And the impact now is we still, our first line of choice is to have a discussion with online medical control. We have a patient who is either expired or is imminently about ready to expire. We have a DNR, this is what we have for information, it's signed, it looks like an invalid DNR, and we just kind of get their blessing on that, just so that we have some sort of backup to that. It's not an independent decision, although it is in our scope of practice to recognize those that are a legitimate signed DNR that meet the certain criteria. But we do try to, as backup, involve online medical control early and often in that. But if for some reason we're in a bad cell spot and we can do it independently. But it's a much more streamlined process than it used to be. It used to be very complicated. They had to be dated within a year. They had to be an original. It was very complicated. And they, as DNRs have become kind of a matter of course in healthcare to the extent that they are, it's less of a scary, what do we do situation than what it used to be.
But can the physician that you're in contact with deny that?
We always defer to what our online medical control is. So there may be, and I've never run into this, but there may be situations where a certain intervention is necessary that would preclude the patient from expiring, that they might direct us to do. But I've never run into that.
Okay, so those of us who want to take a tour,
There's Rob here, the chairman of the board that's here, Bridget Spofford,